So many people don't understand that addiction is a disease, and it's a terrifying disease because it affects the brain, right? And if you have a disease that impacts this area, just like with Parkinson, where they have issues with emotion, cognition, with memory, with pleasure, with pain, it's just a different population of people and how that consequence gets expressed. So it's a challenge. It is probably our biggest challenge, is helping people to have better informed decisions about this disease and the individuals who suffer from it.
You're listening to Mind Your Wake, a podcast sharing ideas in good business from Canopy Media. I'm your host, Elshadai Smith-Mensah. Today we're talking to Dr. Dawn Forbes, CEO and founder of Nascend, a B Corp certified company that has developed innovative solutions to improve outcomes for infants and families affected by substance use disorder.
We were founded in 2016, and really we were founded to kind of meet a need that I couldn't meet otherwise. I'm a neonatologist. I take care of sick babies in the ICU. Been doing that for about a decade. And in 2011, here in Kentucky, we began to recognize that we had a growing population of infants that were born exposed to drugs in utero. So moms with problems with addiction, moms that were stable and active in their recovery, even moms that were taking prescription pain medications. All three of these scenarios are moms that are actually taking opiates, whether it's illegally, illicitly, or legally as prescribed, or very importantly, even moms that are doing all the right things and they're in recovery and they're stable in their treatment. The medication that they take is also an opiate. So in 2011, within my healthcare system, as we began to see literally a threefold increase in the number of babies that we were providing care for, as a practice and as a neonatologist, I began to recognize that we needed to do a better job taking care of these babies. We needed to work on a shorter length of stay. We needed to look at better guidelines and treatment protocols. We needed to look at not just minimizing the amount of pharmacology, but when we had to use pharmacology or medication, doing a better job of that. And over the next several years, with the support of my healthcare system, as well as the support of my practice and my partners, we began to develop guidelines and care protocols and just really an approach to care, which we call our continuum of care, that really began to make an impact in improving the outcomes, not just for the infants, which were our initial and main focus, but also for the moms, for the pregnancies, and even going on to have women that are not only just pregnant, but they also get the opportunity to be parenting on the other side. So helping the babies, the moms, and even the families in a more global approach. And when we think about our continuum, we talk about taking care of these moms, infants, and families from beginning of pregnancy, the first trimester, and following these infants all the way through 3-year developmental follow-up. Now, that was all within my healthcare system, and we made great strides. And really, in Kentucky, my healthcare system does literally the best care in the nation. We are hands down, we provide the best care in the nation for all of our patients, but especially for, infants that have in utero drug exposure or substance exposed infants. But we reached a point to where we were not able to move any further, and I wanted to be able to take what we had done and move beyond my healthcare system and begin to make more of a national impact. And with the support of my healthcare system, we were able to start making some strides to doing that, and that's how Nascend came to be. So in 2016, I established this company. I have some great support. My investors, several of them are neonatologists as well, people that believe in this cause, believe in this population, and believe in me. And we have been moving forward for the past 2.5, going on 3 years, just putting together education guidelines, training protocols, creating technology, creating apps, doing all kinds of things that help us take what we learned as practicing neonatologists, as clinicians, and turning it into something that we can provide nationally for other healthcare systems and healthcare providers.
I guess it's exciting as a business major to hear that you're answering a need, right? And it expands beyond Kentucky. So what is that like scaling throughout other states?
It's interesting because every healthcare system has their challenges. And when we're talking about doing something that is a more unified approach to care, more unified approach to guidelines and answering problems, you have to recognize that just like, no mom in recovery is the same, and no baby that's born substance exposed is the same. When you talk about these healthcare systems, every healthcare system is dealing with a little bit different population, different politics, different regulations, different space constraints. I mean, even when you just talk about the physical space that we need to provide care for these infants. Some people have a really high-tech NICU, others are still using paper documentation. So when you try to put all of these different facets together and then combine not just the healthcare component, but how this integrates, it has to integrate within your community, right? Because it's not just us as doctors and healthcare workers that are going to make a difference. We have to integrate with the other systems like social work, like child protective services, like addiction treatment centers, the OBs, the pediatricians. All of this is outside of neonatology, nurses and nurse practitioners across the spectrum, but also the foster families and the moms and dads themselves and their extended families. When you start looking at all of these different dynamics, they are slightly different from community to community, state to state, healthcare system to healthcare system. So what you're scaling has to be flexible. There has to be a core understanding, and our three guiding principles are family-focused care first and foremost, education at every opportunity to provide that education, and then the continuum to where we're not just dealing with one piece. We're not just putting a Band-Aid here and a Band-Aid there. We're truly trying to put solutions in place that can extend the entire spectrum from pregnancy to 3-year developmental follow-up. So if you have some core foundations that you stay focused on and some flexibility to adapt, and that's where technology helps us. The apps we've created and all of this really allows us to be more flexible. Then you can start addressing not just the structure that you're used to and where we developed this, but where we're now implementing and working with other care providers. And honestly, at the end of the day, you have to listen. You have to go in open-minded and know, I've learned as I've come across this, that as great as we do things here, there are a lot of places that do pieces even better. So, I always say, I am happy to borrow from you what you do excellently, and I'm happy to share what we do equally back. So a lot of what we have built and grown as I've left my system and moved into this Nascend, this more corporate approach to trying to improve care, a lot of it has come from collaboration with other hospitals and understanding the things that they do that are really awesome, that are even more diverse, more scalable solutions to problems than what we envisioned because we were in one system. So.
And you kind of referenced it, right? It's not just what's happening in the hospital, but it's what's happening at home, social workers. How do you even begin to balance that many stakeholders, in one situation?
That's an excellent question, and it takes time and patience, right? And you've just got to figure out, so, when we started this, it was really kind of a grassroots movement. And when we started, I was actually a private neonatologist. I wasn't we practiced in the bigger healthcare system here in Kentucky, but we were private. So we even had a little different perspective than those that are in these bigger healthcare systems. But you have to be patient, and you have to figure out what it is that motivates people, honestly. So when I went to talk to OBs and said, I need you to start referring moms to me, right? I mean, well, the OBs want to do a good job, but at the same time, their job is to take care of the pregnancy and the fetus, right? And now suddenly there's this addiction component, and they just don't have the resources. So when I went to them and said, I need you to start helping me in a compassionate, non-judgmental way, helping me to identify these at-risk moms and then sending them to me, the best thing that I could do is say, if you'll identify them, I'll do all the prenatal consultation. So taking what I know that they could do within the scope of the resources that they had, but then giving them a really big resource, and then helping them to come to the realization that where they may not have the resources to deal with mom's addiction component of her pregnancy, but they need to know about it, because what she's taking and how she's doing and her, what she's choosing to use during pregnancy, what her medications may be, if she's still active in her addiction, what those consequences are, that all impacts the pregnancy and the fetus and the newborn. So you have to just kind of know where people are and know what can help motivate them to do what they want to do, because everybody wants to do good. No OB doesn't want to help with addiction, and no addiction treatment center doesn't want to help with the pregnancy, and no neonatologist doesn't want to help with the mom. But we are so quagmired in where our limited scope and resources are that once you start opening that communication, and I know what you need to do what I need, and I can provide this, and I can get OB to provide that, and I can get addiction to provide this, then suddenly you have this collaborative approach with everybody doing just a little bit more than they used to, and everybody helping each other out to ultimately have better care for mom and baby.
This podcast is brought to you in part by BKD, CPAs and advisors whose expertise go well beyond the standard accounting services to help address your challenges with an array of solutions, including risk management, digital transformation, wealth management, business transition services, fraud investigations, and valuation services. Learn more at bkd.com.
According to Nascend, the average cost of treating an infant with neonatal abstinence syndrome is $93,400. With 75% of these infants being covered by Medicaid, the United States is paying a major portion of the aggregate cost, which is $2.5 billion. So in addition to improved outcomes for babies and their families, Nascend's new paradigm of care stands to save a lot of money.
So, as I mentioned, for us in my healthcare system, this came about in 2011. And what we recognized was that we had length of stays that were 44 days. So really long time if your baby needed to be treated. We had healthcare providers that didn't understand addiction was a disease. We had moms and families that weren't seeking healthcare because of the stigmatization. We have nurses that were so frustrated because they came in and the babies were crying and distressed, and there was nothing they could do to make these babies better, so that when they went home, the babies were still crying and distressed. We had nurses that were ready to quit because they just couldn't do what nurses are trained to do: make people better, give comfort, provide care. So we really had to focus on those things. We also didn't have great guidelines of even how to go about doing this. So there was very little literature available on how you treat these. There were definitely some pioneers. Dr. Loretta Finnegan has been a pioneer in this work since the 1970s. I mean, she's done lots of work. So we had a few pioneers out there, but we didn't have really clear guidelines of how to treat, when to treat, even what to treat with. The few guiding sources that we have from our governing bodies like the AAP and ACOG, they basically had more general statements: treat opiate exposure with an opiate. So when we started looking at this, one of the first things I did was I figured I'd just do a quick literature search, right? Clearly this has been around for decades. Well, there wasn't anything there. The next thing I did was turn towards healthcare systems, big academic centers, right? Because they're always in this space. They're always advancing, what we know, our resources, how we provide care. And when I went to them, everybody says, yeah, we're seeing a problem too. But when you figure it out, call us back, because we need help too. So a lot of this was just taking a look at the fact that we just didn't have a lot of guidelines. Basically people used a handful of different medications, including crazy things like tincture of opium was still being used in 2011. I don't even know how you get that, but I did a national survey and people said, yeah, I use morphine, I use methadone, I use tincture of opium, I use diazepam. Things that seemed a little crazy once you begin to understand how the mom's substance use during pregnancy affects the fetal and then the newborn brain, but we didn't have great guidelines. So one of our first steps was we had to figure that out. We had to figure out how we could start doing a better job. So we started with a length of stay that was 44 days in 2011. Now we can actually, even our babies that have to be treated, we can get them in and out of treatment in as little as 12 days and up to, in our worst scenario, 19 days. Also back then, we were easily treating, immediately getting newborn babies and committing them to go to the ICU, a higher level of care, a more expensive level of care, a terrifying level of care for families that all along thought their baby was fine until suddenly now the baby is born and the baby's not. And not only are they not okay, but I'm going to put your baby in a NICU, scary place, and I'm going to keep your baby for 6 weeks, super scary, right? So we had, in that scenario, we had 65% of our babies that we were treating back then. Today, we treat between 35 and 45% of our babies. So we've got protocols and guidelines in place that we just do a better job of non-pharmacology intervention, not having to provide medication, doing other things that are within the parent's control and in the newborn nursery and without escalating that care. We had average costs that were $40,000 to $50,000 to provide care for these infants because of the length of stay, because of the higher level of care. We've decreased that by almost 70% today per baby. So substantially lower cost to care for these kids. And then, as I mentioned, Families are now more likely to seek not just OB care, but also addiction recovery care. Families are more likely to see other healthcare providers. They're more likely to engage in community resource programs just because of the positive experience they have within our healthcare system and within the approach that we provide. And if they've ever had a baby with us before, then when they have that next baby, because inevitably they will. I mean, these are individuals that are raising families. This population of women that use substances during pregnancy. It's not just the ones that are illicitly using. It's not just the ones that are active in their addiction. Many of these individuals have families, have significant others in their life. They're on their second and third child, and their baby is still at risk of withdrawal, though, because the medication that they have to use, methadone and buprenorphine, the medication that we use to keep people stable in recovery, to keep people healthy, to keep that brain quieted down and provide some recovery to the effects of that long-term drug use. Well, it's an opiate. So even with all the best conscientious decisions, many kids are exposed to very stable, very healthy families, and they go through withdrawal. And when we have parents that come back and they've had a child with us before, they come back even more engaged, even more excited, and even more ready to be involved. We went from basically none of this population breastfed to now 60+% of our moms breastfeed, and they continue to provide some level of breast milk up until a month of age. Whereas nationally, when a baby is admitted to NICU for treatment, most babies in this population, babies that are born with substance use or with NAS, most of them stop providing breast milk at 6 days in the hospital. We're able to keep our moms at least pumping and providing some breast milk to a month follow-up, which is 6 weeks of life, which is tremendous because we all know how important when it can be applied and used safely, effective, and beneficial breast milk is. We were able to, like I said, go from nurses that were ready to quit to now they actually primary these families, which means that they come in and they take responsibility for the family and they want to take care of that family every day until that baby is discharged instead of just trying to get through their shift hoping they don't have to come back the next day. Big changes. Our parents come in now. They're more forthcoming about their medical history. They're more forthcoming about their treatment program. And when they relapse, they are more forthcoming about that relapse because they know how important it is for us to know to take care of the fetus, the pregnancy, or the newborn at the time that it occurs. Also, as part of this, we just have a much better collaboration. Our community addiction treatment centers talk more with our OBs talk more with our NEOs are talking more with pediatricians. Pediatricians feel more informed as they're getting these kids now to follow them for a much longer time, than the 2 to 3 weeks we take care of them in the NICU. They're now going to follow these kids for 18 years and all the subsequent effects that may be there because of that exposure. It's just tremendously better what our communication is. As a matter of fact, as part of this, I actually now work in one of our local treatment centers, Center for Behavioral Health, and I do have their permission to say that. They are actually one of the largest addiction treatment centers in our country. They're in the top 5, if not maybe even in the top 2. But they are an excellent example of how when I reached out to them and said, what can we do to help these moms do better? They stepped up and said, let's do this. We'll open our doors to more pregnant women because you guys probably know that, first of all, men and women need very different addiction treatment, right? And all of our programs are geared towards men. So even finding a program that can be very effective and beneficial for women is a challenge. But many of those programs, when that woman becomes pregnant, they discharge her from the program because that's 2 patients, right? They'll take care of the mom, but they won't take care of the fetus. So many of these individuals, when they do find themselves pregnant in recovery, find that they have to leave their recovery center, and there's not a lot of options. So Center for Behavioral Health stepped up and said, yes, we will absolutely take care of these moms. We'll take care of ours that declare pregnant, and we'll even take care of those out in the community that need to find another treatment program for the duration of their pregnancy. They also begin to work with the moms because in the state of Kentucky, it's not that you can get free treatment during pregnancy, but you can defer your payment. So in other words, you kind of have a guaranteed treatment while you're pregnant, but that bill is accumulating every week. And you guys may know that that's $100 to $150 out of pocket every week just for moms to get their medication-assisted treatment. And most of our programs, except the few that are state-funded, or pay for fee or pay for service. So it's out of pocket. They don't take insurance. They don't take Medicaid. But this program stepped up and said, we'll work with moms on the other side of that. And because of that, I began first to work as a consultant and then to do group sessions. And now I'm actually part of the staff and I'm a buprenorphine provider. So I actually provide buprenorphine and am part of the education, the counseling, and the management of moms from the time they declare they're pregnant up to 12 months postpartum with CBH. So just an example of how the community stepped up, just an example of one program that stepped up. There's other programs. You guys are very familiar with Choose Well. I know Choose Well is very integrated with you guys, with us. And this program all came about at about the same time. And they've stepped up and they really said, well, there's more than just medication, right? So they've got all these other services that are wrapping around and they take our moms and they help with our moms. So lots of great programs that our community stepped up. So we began to make a difference in the community, not just in healthcare, which then trickled down to foster care, to social work, to child protective services. We've even talked with judges and attorneys and parole officers just so that they have a better understanding of the population they're providing care for and the challenges that are going to go beyond just people with addiction, because now these are parenting women. These are women that are pregnant. There's all new challenges that all of us face as being pregnant or as new parents or as having, another life to keep alive, right? Not just yours, you now got to keep somebody else alive. So it just really, that's been another big benefit of where we were in 2011 versus where we are so much better today. So we have treatment guidelines now. We have improved outcomes now. We have engaged families in their pregnancy, in their recovery, and in the care of their newborn. We have an engaged community. We have an engaged healthcare system. All of these individuals coming together to make a difference in the lives of these infants and the moms and these families. And you guys all know that what we pay up front comes back to us 100 times fold in the long term, in our community, in our environment, in our healthcare dollars, in the outcomes of our kids, right? Because we put about 400 of these kids into kindergarten every year. About 400 substance-exposed kids enter into our education system. The better job we do in those first 4 to 5 years, the better job we're going to do when they get into our education system and going forward.
As part of the continuum of care for families, Nascend's approach emphasizes comfort for substance-exposed infants, which improves their feeding and rest. One of the most successful tools to comfort these babies is music.
We have about 30 years of experience in knowing how very powerful music is to change behavior, both bad behavior when we're older and help us to develop good behavior when we're young. And we began to look using different techniques with music, some contingency, where basically we provide music as a reward when the baby does what we're asking them to do, and some just to engage parents so that we teach parents how to use music. And the music you want to use is lullabies. You don't want to use any other kind of music in kids that are definitely in this first 6 to 12 months, maybe even up to 2 years old, because lullabies are exactly what these kids can respond to. But lullabies are repetitive, they're rhythmic, they're predictable. Babies can settle into it and anticipate the next words, right? I mean, think about all the lullabies you know, right? Like Twinkle Twinkle. It has a chorus and then a verse and then a chorus, but it's repetitive and it has these falling sounds, right? That you can just fall into them and come back out. And Michael's taught me all this because I didn't know any of this when we started several years ago, right?
So my name is Michael Detmer. I'm a board-certified music therapist, and I have a NICU specialization, and I am an educator for Nascend. Music therapists, we are similar to physical therapists, occupational therapists, speech therapists. We just use music as our tool or our medium to achieve some sort of goal. We use music to help infants calm. So sometimes when they're in the NICU and they're in a state of pretty severe withdrawal, they're showing increased symptoms, it's hard to find anything that works to help calm them down. So we'll use music to get them from that place of inconsolability down to a quiet, comfortable sleep state. And that looks like live singing. We get them into their favorite position, and we use sometimes stroking or patting, and we synchronize the tempo of that with the music. And over the course of the next 5 to 15 or 20 minutes, we slowly decrease and change the complexity of the music to bring that to a more calm state, while simultaneously bringing the baby along with us. Another area is working on feeding ability. So a lot of these kiddos have feeding difficulty where they either aren't very coordinated or organized is what we call it in the NICU. They don't really stay focused. They have a really fast suck rate or maybe an ineffective feeding pattern. So they waste all of these calories and all this energy just trying to latch onto the nipple of the bottle. And meanwhile, they've got milk rolling down their chin. And the nurse is frustrated and trying to get all of this volume in the baby because we want them to grow. But the baby is just in so much withdrawal and discomfort that they can't really focus and engage in that. And then meanwhile, the brain is being wired to think that every time a bottle is in my mouth, it's a negative experience. So we use music to rewire and help the baby learn to have a more organized and comfortable feeding and keep the baby nice and calm and in a place of homeostasis during the feeding, so that is then viewed as a pleasurable experience, and they're using their energy efficiently. So we slow down their suck pattern. Again, babies suck at like about one suck per second, so 60 beats per minute. Usually kids with NAS, they have a really fast and ineffective suck rate. So we can sort of match the tempo of the music and then slow down the tempo of the music over the course of the session, and the baby will slow down their suck with us. It's called the principle of entrainment.
Baby, it's time to eat, time to eat. You're oh so sweet. Baby, baby, it's time to eat, time for a treat.
One of my former mentors and now a really close friend taught me this phrase. It's commonly used, but like every person is doing the best that they can with what they have at that moment. When I think about that, of like even the people here in this community that like they have a home environment or a work environment or an upbringing that has depleted them of appropriate coping strategies, that the only answer for them is drug use, that really brings this into perspective. And then you meet them in the hospital and you see like they are doing everything that they can to make sure that the baby has the best care, and we might struggle with them being late or them not sort of being responsible for all of the parenting care, but we don't always see the big picture. And I think she's still a mom that has a baby in the ICU and she is doing things right, but the baby is still experiencing neonatal abstinence syndrome.
Nascend has already trained thousands of healthcare providers, but as you can imagine, for Dr. Forbes, launching and scaling the business while continuing to practice has been really challenging.
I would have never thought that 10 years into being a doctor after 20 years of education, that I would be leaving clinical care and running my own business. I mean, that is definitely a detour. And that detour comes about because what I have learned since I started in this population in 2011, because I should probably go back one step and also make one comment that when I took this project on in 2011, there was an ulterior motive because I was the only non-partner in my practice. Everybody else in my practice was a partner, and I wasn't a partner. And so when I took this on, and if I were being honest, I was more voluntold than volunteered to do this, and happy to do it. But I thought this would be easy, and I would get some guidelines in place and solve our problems, and I would make partner and then continue as a neonatologist. Even a year into this, I couldn't have envisioned that my entire career was going to change to have such a focus on this one. And it's not just one disease, but on this one population that's focusing around this handful of diseases and handful of ways that we provide care. Now, I couldn't imagine doing anything else today, right? But if you'd have asked me, and as a matter of fact, many of my partners will tell you that back in 2011, they used to say things like, Dawn, you're getting too worked up. It's just a task. It's not the rest of your life. It's not your career. Of course, they're eating a little crow today because lo and behold, it does look like it's going to be a big part of my career. But definitely, that's been a learning curve. And when I started this, I didn't know anything. I mean, I know I'm considered an expert today in maternal substance use and exposed infants, but in 2011, I couldn't even do a Finnegan assessment if my life depended on it. Like, I probably couldn't even list all the symptoms that babies who go through withdrawal have, nevertheless be able to identify all of them on a scale of some, none, and a lot, right? So I had a lot to learn. It's definitely been a big learning curve. And then just understanding where the resources we had weren't as effective as they needed to be. And then moving all the way forward after we started to get some clinical success to realizing that if I really wanted to make a national impact, if I really wanted to make a difference, I had to start a company. So now you've got a doctor and a bunch of other doctors starting a company. Luckily, I had some amazing people come on board, like Tally Russell, who you guys have talked to, who brought some business perspective. And one of my partners is very, very strong business acumen. So, just kind of sort of grabbing people's interest more so than their training, their skills that they've acquired over the years and started putting it together. Big learning curve. I'm all about handshake deals, right? Well, they don't exist anymore, right? Even in the world of B Corp, as much as there's so much compassion and so much, public benefit and for the good of people and the good of progress and all of that over profit, there's still an underlying component of profit. And I think whenever there's money, there's a learning curve, right? I mean, we didn't necessarily make some of the best business decisions as we started up, and that's been a learning curve. Being a female, and as a CEO and trying to start a company and trying to get funding and trying to get people to take me seriously. I mean, I had the advantage of being a doctor. I mean, I feel for women that didn't have that little extra something behind them, right? Just, a female with a strong desire to do something and the skills to do it. I mean, I think the one thing that kind of helped me to continue to move forward was that I was Dr. Forbes, not just Dawn Forbes, right? There was power behind that education, behind that title, and then just amazing connections. So Nascend we're still relatively a startup, right? We are still trying to get all of our products launched. We're very excited that we were able to train in 30-some states last year. We impacted thousands of healthcare workers across dozens of different healthcare systems. We are continuing to do that this year.
Since my original interview with Nascend in mid-2019, the company has launched Nascend Learn, a comprehensive curriculum of online courses and video workshops for healthcare providers and institutions. My colleague Ben Smock caught up with Dr. Forbes on the Canopy Cafe, where Dr. Forbes shared a little more about the program.
Nascend Learn is a comprehensive online curriculum that has recently been launched. So tell us a little bit about that.
So just like everybody else, we've been impacted by COVID-19 and just the changes that we're seeing across our country and across the globe. I mean, because this is not just our problem. This is a worldwide problem. And in order for there to be a solution, this is going to have to be a worldwide solution. I think that's really important. But for us, just very individually, the training that we did, I mean, what Nascend looked like pre-March was me being on the road, physically out there in hospitals and healthcare systems. I mean, 270 days last year, I was up in the air and on the road and traveling.
Wow.
And I have been in a plane 3 days since March. So big changes. And I'm thrilled that I have such an amazing team of people that have worked with me, because we basically took a handful of videos that we had been sort of with a vision creating over the past couple of years, but never really got it together. And we were able to go from that handful of videos to 18 online courses that allow a provider in their own time, at their own pace, to go from everything about prenatal intervention all the way up to 3-year pediatric follow-up and everything in between for the substance-affected infant and family and mom, and have an online learning experience. And although, again, I still firmly believe that live training and live education is the most beneficial and the most impactful, in a time when that's not possible, I was really proud of my team for being able to recognize that this was our opportunity. So we launched Nascend Learn in the end of June, and we're really excited. It's for all healthcare providers and anybody across the space, whether you actually practice medicine or you're part of the social support system in the community or in the healthcare environment that takes care of these infants and families, works with adults of substance use disorder and addiction, obviously focused on maternal and women and pregnancy. But it's really been our way to try to continue to put information and education and training out there in a obtainable, usable, and accessible way, given the change in our times now.
Mind Your Wake is produced by Ben Soley and me, Elshadai Smith-Mensah. For more information about Nascend and their training programs, head over to nascend.com. That's NASCEND.com. As a B Corp certified company, Nascend is part of a global good business movement, striving to make a positive impact on people and our planet. Here at Canopy, we're aiming to bring that movement home to make Kentucky first in good business. Our Canopy certified program helps guide companies from intuitive good to intentional, measurable good. To find out more about our work in Kentucky's good business community, head over to canopyky.org. And while you're there, please consider making a charitable gift. Like many nonprofits, these are challenging times, which makes the work that much more important. Thanks again for listening to Mind Your Wake. This is the final episode of Season 1, but don't worry, we'll be back in your feed soon sharing more ideas in good business.